Welcome back to PedsCrit. I'm Zach Hodges.
And I'm Alice Shanklin. And today on PedsCrit, we're diving into a topic that I think is so appropriately niche and so important, and that is pediatric acute liver failure.
And to do that, we have Dr. James Squires as our specialist and guest. He is a pediatric gastroenterologist and transplant hepatologist at the University of Pittsburgh School of Medicine. He received his medical degree from the University of Texas in Galveston and completed his residency, followed by fellowships in pediatric gastroenterology and transplant hepatology at Cincinnati Children's Hospital. He is an NIH-funded researcher in pediatric liver disease and the first author of the 2022 Pediatric Acute Liver Failure Clinical Guideline.
That's right. We've got another guideline author on PedsCrit to share their information with you. I also want to thank Maria Pliakas for doing this episode with us. Maria is a critical care fellow at the University of Michigan. She was there for med school and residency. Her background is in data science research, and she's interested in the way that we can best sedate patients with acute liver failure as we bridge them to transplant. We are so grateful that Maria reached out to us and that she was able to recruit Dr. Squires for this episode.
Yes, so excited to share this with our audience. Let's get right to the episode.
We are here today with Dr. Jim Squires and Dr. Maria Pliakas. Dr. Squires, can you tell our guests something about yourself and include something that you enjoy outside of medicine?
Yeah, sure. Hi, I'm Jim Squires. I'm a pediatric liver doctor at the University of Pittsburgh. Really excited to be on this podcast today talking about something that is near and dear to my heart. Something that I enjoy outside of the hospital. I tell you, I grew up playing a variety of different sports, but never in my life did I hold a paddle. Like I did no paddle sports, like ever. But here in Pittsburgh, there is something called platform tennis, which is like unique to this part of the country. But it's like a combination of like racquetball and tennis and squash, maybe. I don't even know because I don't have a paddle history. All I have to say is that it's a paddle sport. It is played outdoors in the winter, and it's on a platform that has like these like very low grade heaters underneath. It's like enough to like melt the snow but not keep you warm. But I'm getting into this as like a sport now, and I very much enjoyed it, and I've been very humbled by people that don't look the part of an athlete, but have had a paddle in their hands before, and they just toy with me. So it's a humbling fun.
Wow.
How about you, Maria? Yeah.
So hi there, I'm Maria Pliakas. I'm a current second-year fellow at the University of Michigan, and I got to join this podcast because liver failure is one of my favorite topics and clinical interests, and things that I like to do outside of work. Typical, I love reading, I love doing puzzles. I actually have an Advent puzzle calendar for the month of December that I've been working on every day. And then I also have 2 French bulldogs, and so they definitely keep me busy and love hanging out with them.
So very fun. Jim, tell us how you became interested in liver failure and what your current areas of research and professional areas are here.
Yeah, sure. So liver failure is something that is kind of near and dear to my heart for many reasons. I think for those of you who maybe dig a little deep into the pediatric liver failure literature, there is another Dr. Squires, whose name you may see pop up quite often, who was actually my father. This was not like one of those things that was a foregone conclusion. I've said this before. I don't really think I knew what he did until I was like a second-year med student. Like I knew he was a doctor and he did stuff. I didn't know what. Because he didn't talk about it. So, but he was the PI on the NIH-funded PALF study group, which was active from the early 2000s to the 2010s and kind of pumped out a lot of the kind of literature on PALF and is the basis for a lot of what we know in PALF. And so when I became a doctor, it was an interest that I had, and I think there were some unique opportunities in Pittsburgh where I landed. And it's something that I kind of fell into a little bit. I've come to love it because it's not one thing, right? I mean, it's a million different things with a million different ways to approach it. And so I think it really makes you have to think. It really makes you have to kind of take a broad view and approach each case as an individual case and not as like a process.
Oh, sure. And the complexity of liver failure is why it makes a great topic today. Now, there's a bit of a Dallas connection, if I'm not mistaken, right?
It is, yeah, the Dallas guy. I grew up in Dallas. My parents were at Southwestern for 20 some odd years, and they left in the early 2000s. But yeah, I grew up in Dallas, went to high school there, went to med school down in Galveston, University of Texas. So yeah, a lot of Texas connections.
I can't believe the family history of hepatology is like so beautiful, and I can't believe I'm just learning this now.
Yeah, it really, yeah. There's actually in pediatric liver, there's a few of us whose parents did the same thing. So I think I've got friends in San Francisco and Cincinnati, and their parents and were GI physicians, and so it's a little club we got going for us.
So as we wrap up our intro, any conflicts of interest to disclose today?
Not here, no.
Fantastic. Maria, do you want to give us our clinical case and first question?
Sure. So our case today, we have a 4-year-old male who's being transferred to the pediatric ICU with acute liver failure and concern for hepatic encephalopathy. He was previously healthy, but was admitted to the hepatology service 3 days ago with jaundice, abdominal pain, and concern for acute liver failure. Over the past 2 days, he has had worsening irritability, and he's now more somnolent. He's also had worsening markers of liver injury and synthetic function. And so to start us off, let's talk about what exactly is acute liver failure.
It's a great question. Is that one to me?
Yeah, it is.
Do I take that? Yeah, this is where I do kind of get on a little bit of a soapbox here, and I apologize for the preaching, right? But people will talk about pediatric acute liver failure as if it's a diagnosis, right? And as if it's a CPT code or something, or an ICD-9 code. And at the end of the day, it's important to recognize that there is a quote-unquote definition of pediatric acute liver failure. I think most of us are familiar with it. It really has a couple different aspects, which I'm sure we'll maybe touch upon later. But briefly, right, it's evidence of biochemical liver injury, and then this magic number of an INR greater than 2, right, with or without encephalopathy. And so I think it is important to realize a few things. One of which is, this definition of acute liver failure was really something that was just decided upon by a bunch of really smart people in a room one day, when they were trying to come up with how to best identify a specific population of kids that were at risk for liver failure and the need for liver transplant. What it was originally designed to do was to essentially be the entry criteria for a registry study, right, for that PALF study group that was being funded by the NIH. And they'd say, who are we going to include? We need to come up with a definition of who we are going to include. And the reason I say that is because it has become now the standard definition, which is good, right? There's many things that are good about having the standard definition. It allows us, obviously, to study a rather homogeneous population. It allows us to kind of combine studies across centers. So there's a lot of good things. But it's important to recognize that a kid with an INR of 1.8 and encephalopathy, to me, is just as scary as a kid with an INR of 3 and no encephalopathy, right? So, just because we haven't reached some of these predetermined cutoffs for what has been historically defined as acute liver failure does not mean we shouldn't be very, very worried about the clinical progression of this kid. When people ask me what the definition of acute liver failure is, I obviously give them the kind of standard entry criteria definition, but I'm very careful to point out that that is just an entry criteria definition. And vice versa, right? I think sometimes you can have a kid with an INR of 2.1 who's totally lucid, right? But if you think about, liver transplant, for example, where some of these kids do need transplant, if someone looked at that kid with an INR of 2.1 and had no encephalopathy, they could decide to list that kid for a liver transplant, and that kid would go straight to the top of the list because he would be categorized as status 1A. And so you just have to be very careful about that, or at least cognizant of that, in that at the end of the day, it's a definition. It's a definition that was developed to identify a population, but each kid is still very much an individual child that needs to be assessed at the bedside to really understand how well they are clinically and where they're clinically progressing.
And I really appreciate the context with the research link there. For the bedside clinicians, will you tell me more about why it's important that we delineate acute liver failure from maybe acute on chronic liver failure?
Yeah, acute on chronic liver failure is a whole different beast. And to be perfectly honest, there probably hasn't been as much formalized study of that condition and what it means and what drives it in kids. And so, we could have a whole separate podcast of acute on chronic. To your point, right, I think there are some people who have kind of published or tried to publish the distinction between acute liver failure and really those that are acute on chronic but presenting as acute, right? The Wilson's, the autoimmune hepatitis kid potentially, right? Maybe your gestational alloimmune kid. And so, there are some differences. And at the end of the day, I think we just have to recognize that when we talk about acute liver failure, we're just talking about someone who, as far as we know, didn't have liver disease yesterday and has liver disease today. By yesterday, I mean, more in the recent past. There still can be acute presentations of chronic liver disease, and that this entity seems to act differently than, again, the acute on chronics and obviously the kind of smoldering chronic that gets worse over time.
Right. So I'd like to talk more about how we deliver care to these patients with acute liver failure. So our hepatology service here locally, they do a great job. They manage many of their patients outside of the ICU. And I do find that sometimes as their lab abnormalities worsen, maybe their mental status starts to drift a little bit, that is when we have to make a judgment call when to bring them to the PICU. On the other hand, our patients who are developing shock or respiratory failure, it's very obvious when they're going to come to the ICU. But could you share with us, what are some general criteria when we should bring these patients into the ICU when it's unclear? They don't have a slam dunk diagnosis or a reason to come to us.
It's a great question, and one that doesn't probably have a clear-cut answer. We talked a lot about this when we published the guidelines recently about what should be criteria for ICU admission. And I think there's always some discussion and some debate. And at the end of the day, it comes down to level of comfort. But, in general, what I try to practice here is that if it is a child that's coming in through the ED, just back to Zach, your prior comment there, most of the time, again, if they're truly acute liver failure, it's usually unlikely, or most of the time, they don't come in from the hepatology service, right? There's that rare kid that comes in and gets, sicker over time in the hospital. But a lot of times they just show up in the ED and you're getting called because the INR is 3.2, or from an outside hospital because they landed in their ED or the pediatrician called. And so, for that kid that really is showing up acute, that no one's really laid eyes on yet, that no one really has seen yet, even if they have, minimal to no encephalopathy, if the INR are really above 2, I think putting that kid in the ICU at least overnight, because these kids can decompensate very, very quickly. And they really need that one-to-one nursing to be able to do Q2-hour, neuro assessments. And I have seen and worry that isn't always able to happen on the floor. And again, it's not that the floor can't handle these kids, but it's just that they aren't staffed to be able to keep the eye on these kids that is required. Now, probably, it wouldn't be a rare occurrence that kid comes in, spends the night in the ICU, is stable, and then comes out, right? But I think those first few hours, those first 12 to 24 hours of a kid in acute liver failure, where you don't really know what direction they're heading, is a time that I think really needs ICU management. Maybe not so much for the tubes and lines and things that you all can put in, but really for that one-to-one nursing assessment to really keep an eye on how the kid's mental status is progressing.
Oh, absolutely. And that's such a clean barrier.
Before we move on, Jim, you bring up a point that really resonates with me, and it's that I feel like on general pediatric wards in general, we are trained so well to detect the critically ill child who's developing shock or respiratory failure. But that patient who has the subtle changes in mental status is so hard to detect, especially when your nurse has a 5-to-1 ratio, or maybe you have your one pediatric resident managing 20 patients overnight. The added value of getting this kid who's high risk for decompensating, especially from neurologic criteria, getting them in the ICU, they can monitor quickly and closely. That's so important.
It is really important. And, I think we need to do a better job as a community to figure out how best to monitor these kids, right? Because I think as we've touched upon a little bit, the physical exam is really important, but it's challenging in kids, right? This is what goes back to the original PALP definition. And this is why, the PALP definition, again, it was essentially just stolen from the adult definition. But in adults, right, it's an INR of 1.5, regardless. If you have an INR of 1.5 or above, you have acute liver failure according to their definition. Adult it's 2. And then in kids, they moved it back to 1.5 and then 2 with or without encephalopathy, because of this sense of measuring encephalopathy in a child is so challenging. Right? Because, you take that first case that Maria, brought from the beginning, a 4-year-old, right? You take a 4-year-old who's sick, not feeling well, sleep deprived, you're poking him with needles, you're waking him up in the middle of the night, you're not letting him eat maybe. That kid's going to be stage 2 encephalopathic, just the way we assess it, right? He's going to be grumpy, fussy, he's not going to want to respond to you. These are the kind of subtle things that it's very difficult to pick up in a sick child. And nearly impossible to pick up in a baby, right? In an infant, in the 6-month-old, But having that nursing staff there, that clinical staff there, to be able to try to go, because you will at least see change over time, right? That's where you saw how the kid was when they were admitted. Now you're seeing the kid a few hours later, and clearly there's been this progression. And so I think in the guidelines that we published, I think that we felt that if there was clear signs of complications like hypoglycemia or renal injury or obviously encephalopathy, those kids go straight to the ICU. In my clinical practice, I really feel like, again, if I'm hearing about them for the first time and they meet the definition of acute liver failure, I send that kid to the ICU every time. And if by morning the kid's still lucent and fine and the INR is still in the low 2s, then we bring them out to the floor and come up with a plan. But I really want to make sure that kid isn't one that's going to progress in hours because they can get sick that fast.
So, as we've been talking about monitoring closely for signs of encephalopathy, why do some of our patients with acute liver failure become encephalopathic?
It's a great question. And I think one that we don't fully understand. I think it's one that the field needs to do a better job of defining, right? Ammonia is obviously the low-hanging fruit, right? We all choose ammonia as a proxy for hepatic encephalopathy, and there are clear correlations between elevations of ammonia and degree of encephalopathy. But it's not just ammonia. Right? You can have kids with ammonias of 100, 120 who seem perfectly lucid, and you can have kids with ammonias of 60 who seem pretty encephalopathic. And so I think that it's going to be more than ammonia, but ammonia is the proxy that we have. It obviously has to do with, brain swelling. I think that the physiology is clear, but I'm just not so sure that ammonia is the only offender that's causing the progression of encephalopathy. And so I think it's an area that I think, the adults have led a lot of study in. I think the pediatric world still has work to do. I still feel at the end of the day that, a clinical exam to me is much more important than any blood marker. If you're telling me that, the kid is not responding to you, but his ammonia is 70, I'm way more worried about that kid than a kid who seems to be, much more lucid with an ammonia of 150. You treat the kid.
Oh, absolutely. I would love to hear when you're at the bedside and you're following these patients over a stretch of service, what specific physical exam maneuvers are you doing on the young kids, on the not so young kids, to really tease this apart?
It's hard, and it's age specific, and it just requires a lot of experience, right? I mean, obviously in the older kids who can do kind of more cognizance, daytime location, even some like simple math skills, you try to determine whatever they can do, you try to determine that up front, right? Which is sometimes hard because sometimes they're already coming in sick. Right. But I think no matter what you do, no matter how you choose to kind of, call your exam, in the less than 1-year-olds, it's just nearly impossible to tell between, stages of encephalopathy, obviously short of like stupor and unresponsive. But I think that, in the older kids, I oftentimes will ask the parents, right, like what's a unique skill they have, right? Like what's a word they can spell that mom thinks is really amazing, right? Or what's a dinosaur they can name that impresses the kind of family. You try to figure out what is a baseline thing that they can do that maybe is a little bit, more complex. And then every time you see them, ask them to do that thing, right? Because, doing serial sevens, in a 4-year-old is not going to work. But if he can tell you the name of his top 6 favorite dinosaurs and then do that every time you see him, I think that is something that I'll use to assess. And again, that's not perfect. That hasn't been proven in any placebo-controlled trial. But I think it's my way of trying to figure out where this kid is at and what I'm going to be able to do. I mean, obviously, Istrix and hyperreflexia, those things come with time and are important, but I think it's the subtle changes, I think, in the kind of mental capacities of the kid. And it's still hard, right? Because again, if they're in the ICU, they're getting poked and prodded and woken up all the time. And so it's still never easy. But I guess the answer to your question is, again, I try to find something that's unique to the kid that we can reproduce over the time that I'm seeing him to make sure that he's or she is, continuing to be able to do.
I really appreciate your bedside approach. And of course, the pediatric specifics with naming dinosaurs. It really resonates for me and my kids.
They all like dinosaurs. I don't know why.
Yes. As we'll get to very soon, these kids have multi-organ failure, and it's not uncommon for them to be intubated, respiratory failure, shock, and unfortunately, we'll lose our neurologic exam quite commonly. And I was wondering if you would think it would be helpful to perhaps identify an ammonia level where if it's above a certain level, we should almost certainly assume it's hepatic encephalopathy, or perhaps a low level where we can be reasonably assured that it's not hepatic encephalopathy. Do you think that's fair to do or not necessarily?
For the pediatric acute liver failure study group, intubation equaled encephalopathy. So if you were sick enough that you were requiring intubation, you essentially were considered encephalopathic. The number that I use is just an easy cutoff is 100, right? I mean, just because I think over 100, I'm getting more scared. Less than 100, I don't know why I'm less scared. But again, there's no great data on that. Maybe I just like round numbers. So I would caution anybody, again, just to say, okay, well, he said 100, so I don't need to worry because it's 70. I think if the kid's 70 and intubated, I'm much more worried, right? I don't know why that kid needed to be intubated, but I think, clearly, he could be progressing. There are a lot of other ways that people will assess brain activity, right? I think whether it's EEG, whether it's, optic nerve sheath diameter, whether it's the other kind of, unstudied ways. I think all of these need to be studied more, right? I think for those of you fellows who are kind of traveling across the country, you did residency somewhere, you're in fellowship somewhere else, and then you're going to be attending somewhere else, you'll see that these kids are treated very differently at different places. And a lot of it just depends on what's available, what resources, what the particular critical care doc or neurologist or hepatologist there has comfort or experience with. And I don't think that anybody is right or wrong in this matter. There are various ways that people can do this. And so for those kids that are intubated, I like EEG. I think it provides some useful information. Again, you have to have a good neurologist who feels comfortable trying to kind of tease out some of those subtle differences to kind of let you know how they think the kid is doing. But going back to, kind of the treatment of acute liver failure, right, is that, it is always a little bit tenuous. But I think, kids that are not intubated, getting intubated, these are kids that I'm very strongly thinking about transplanting, right? And unless I know that there's something that I feel like I'm turning a corner in them, trying to come up with, straight guidelines for monitoring certain things is great. But, we can talk about some of the prognostic scores that are out there, but at the end of the day, none of them work that well. And if we're headed in the wrong direction, I'm getting very aggressive about trying to get this kid listed and get him transplanted if I can. And I think, to Alice and to folks like Alice who are, in places where transplant isn't an option, that's actually like step one. You've got a kid in acute liver failure, you need to be talking to a transplant center close by, already thinking about referring this kid to a transplant center, because you need to be able to offer that intervention and you need to be able to do it right away. Because it is true. Sometimes we get kids that are referred in, they turn around in 12 hours and they're fine, they go home. Could have easily stayed where they came from and probably been fine, right? But I don't know that that's going to happen. And I can't tell Alice, that that's going to happen in this kid. And so, you really need to get these kids to places where transplant is offered.
Yes. Definitely travel with those patients to our transplant center. And I'm happy to do it. I'd love to start to talk about where this increased ICP hepatic encephalopathy starts to cross over with our TBI management. In your guidelines, you talk about hyperosmolar therapies. You talk about whether or not you should consider a bolt, even in the setting of the coagulopathy. What's the landscape here? What are we looking at?
We don't know. So this is one of these areas where we have not had the ability to do, the best kind of resourced studies to be able to understand this. And so this comes down to, again, there's going to be institutional experiences that are going to likely drive how many of these kids are cared for at certain centers, right? And, whether it's, hypothermia, whether it's, forced hyperventilation, indomethacin, saline, all of these things, again, it's hard to say that they are right or wrong because they haven't been formally studied in a way that they need to be studied. But I think that, obviously cerebral edema is what kills these kids. And so I think throwing out, all measures to try to control that in the most efficient way possible, I think is appropriate no matter where you land. Here we typically don't tend to do bolts in Pittsburgh. And again, I think that's mostly just kind of institutional experience. I think it's something that, if you have a good neurosurgical team and a good experienced ICU that has, kind of critical care monitoring and everyone feels like it's safe to do, then I think it gives you an incredible amount of information that you can kind of act upon over time. And, I come back to, if we're putting bolts in kids, I want to be transplanting kids, right?
Oh, yeah.
And so this is where, if you are at an institution where you can aggressively manage these kids, however they need to be managed, but what we're talking about is monitoring for complications, not necessarily treating it, right? I guess the hypothermia, that does somewhat treat. But if you're doing really invasive things to monitor, we're in a bad place, right? You get to that place sometimes. But I think that getting that kid aggressively on the list and getting that kid a new organ if you can is probably the best thing for them if you feel like this is a process that's turning around.
Certainly. And we'll get to more about liver transplant. Maria, you had a follow-up question.
Yeah, so I was just going to follow that up with, so we have our 4-year-old in front of us who's become more and more somnolent, and exam is consistent with hepatic encephalopathy. And so what medical therapies are we typically leaning on as effective in this case?
Again, I don't think that there are any effective, proven medical therapies that are kind of best practice, right? And so I think almost anywhere across the country is going to start this kid on the medical therapies, right? Get the lactulose on board. Rifaximin people will throw at, but probably takes longer than we want it to take effect. Probably will want to limit somewhat the protein intake in these kids where you can. Obviously, if they're getting sick and they're on TPN, you want to limit the protein. But neuromonitoring, I think, is the most important thing that we need to do, right? To kind of, again, look at change in encephalopathy over time. which is, again, one of the few prognostic markers that it does seem to kind of come out over and over again with the kind of repeated models that you want to kind of do the simple things, right? Put the kid in a corner bed right away from all the beeps and noises. Try to keep the room dark as much as you can, minimize, some of poking and prodding in the interruptions, right? If you're worried about evolving encephalopathy and an INR that's climbing, and there's things that you obviously you want to get lines in ahead of time, if you feel like you need to be getting your neurosurgeons to come by if you're at a place where you're doing bolts, obviously the sooner you can do that, the better, right? I think people feel better doing it with an INR of 2.8 than an INR of 6. It's kind of calling in all the troops, if you will, right? But again, if you're asking, should we be thinking about hypertonic saline or kind of if it is intubated, the kind of forced ventilation or endomethacin or some of these other kind of case reports, case series, or even, some data in the adult world, none of it has been thoroughly vetted in kids. And so it's just very hard to kind of say definitively. What you can say is this is what's out there, right? This is what other people have reported that has worked. But has it been studied in a critical way that allows us to say that this is, what should be done first? Unfortunately, no, we're not at that place.
Jim, listening to you speak kind of takes me back to managing some of these really acutely ill, acute liver failure patients in my training, and feeling like I have all of these tools available to me, but feeling like they all somewhat miss the mark. I can intubate them and hyperventilate them and increase the blood pressure of vasoactives and give them hypertonic saline, and their liver just continues to worsen and worsen. And I have to look back on my hepatologist in the transplant service and be like, hey, can you guys provide what this kid eventually and ultimately will likely need will be another liver?
Yeah, I think the other important part to talk about is that kind of extracorporeal support, right? I think this is the other, kind of area where I think there's an intense amount of interest in, unfortunately, very little data. They kind of let us know exactly which way to go. And so this, again, kind of falls back on institutional experience. Are you doing, plasma exchange, or are you doing SPAD, or are you doing MARS therapy if you have MARS, or are you just doing, CRRT and renal replacements, right? We use these things to support organs, lower ammonia, cull out the kind of bad humors, if you will, that we think is driving the acute liver failure. And I do think that, most places now are doing some sort of extracorporeal support in their acute liver failure patients. And so I think to Maria's, initial question, probably the most important thing to do is get access, right? And make sure that we have the lines available to do some of these things that we might want to do. But the question as to which one is best and which one should we be doing, I think is still a little bit of an unknown. And again, kind of somewhat comes down to what is your institution comfortable with? What sort of resources does your institution have to be able to kind of provide that support?
I'd love to get your thoughts on if you feel that there's enough literature out there on extracorporeal support, being MARS or SPAD, to have a read on if transplant centers should generally be offering this service. And then the follow-up question would be, in either the absence or presence of literature, do you see centers moving more in that direction regardless?
I think the second question first is yes, right? I mean, I think across the country, you feel like, most places now, I think kids who have progressive acute liver failure are ending up on some sort of extracorporeal. Now, again, the answer to which one I just think is very challenging. I think it's something that would be very interesting to try to study, right? So it's very interesting that I was just at one of the big liver meetings, and I was talking to some folks from European colleagues. And in Europe, there's something, I forget what it's called, it's like the European Research Initiative or something. It's essentially funded by the EU. So it kind of comes from the government. And all that is to say is that they have this very intricate, they showed me this flow diagram that's quite complicated. But at the end of the day, one of the things that they're focused on is acute liver failure. And one of the things that they decided to do first was essentially start up a standardized process for plasma exchange, I think they were doing, in these kids, and essentially coming up with a standardized protocol that all EU centers would kind of agree to participate in, and then study that in real time to see if it's worthwhile. Because you're never going to get enough numbers to do a truly controlled study in this, right? I mean, it's a rare disease to begin with. And then, you have the complexity of, again, every acute liver failure kid is a little bit different, right? So it's not like I'm just going to put every Tylenol kid on MARS therapy, right? Because you're probably just going to get better with NAC. Or it's not like I'm going to put whatever. I mean, pick your disease process. But, it's only those kind of really progressive ones that are getting worse over time where we think to do this. And so you're taking a rare disease and making it smaller. And so we need to come up with a way to do this, right? Because I do think it's a critical question and one that deserves answering. But I think, yes, I see movement, towards extracorporeal support. What that support is, I think is going to be probably different in a lot of the edges. And if somebody's telling you that one is definitely better than the other, I think they're speaking from their own experience, which is fine. That's what we all have to fall back on, but we just don't know.
Now, I'm going to take us back here. If I'm intubating one of these kids, maybe I'm in DC, I'm in the trauma bay, getting ready to ship them to Georgetown, Michigan somewhere. what meds should I be using and what meds should I absolutely not be using to sedate and paralyze them?
I mean, it's a good question, right? I mean, I think that part of it depends on, what we think is driving the acute liver failure, which you obviously don't know at that time. If you're intubating the kid, right, you're losing your exam, right? And so I don't necessarily think that we need to be worried too much about, giving meds to kids who were intubating, I guess, right? I mean, again, I recognize that we always got to think a little bit. I think the flip side of that is, again, the kid that's in the ICU that isn't needing to be intubated yet, right? But maybe who's agitated, right? Or maybe, seems to be in pain for some reason. And so we want to give them something to kind of help them feel better, or maybe we have to, we want to put a bedside pick in them, right? And not necessarily, put them all the way under, or we want to give them some sedation for something. Because those are the kids that I think, what you want to try to do is minimize loss of exam. Obviously the benzos and liver failure is something that we always kind of classically worry about because when the liver function is abnormal, you don't process your benzos as well. But I still, at the end of the day, I try to not necessarily micromanage at that point, right? I mean, we need to do what everyone feels like is best for the kid in this moment. And so if there's a medicine that an ICU doc feels like needs to be given in order for them to get a procedure done, or within reason, I say, let's just, get the kid intubated, right? Protect the airway, and then we'll kind of deal with some of these issues after the fact. But I think if it's like, hey, look, I just want to give this kid a little something because they're uncomfortable, or, we need to place a line and we don't want to do general anesthesia, we try to avoid benzos where we can. We try to give them something, kind of quick on and quick off so that we can get back to doing our neuro assessments and not feeling like there's a medication effect.
Yes, I appreciate that. I appreciate the having your insight, having your recommendations, but also realizing ABC comes first, maybe before liver.
Mm-hmm.
What?
This is a critical care podcast.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.